Hello guys, good morning. Welcome back. I hope everybody's doing okay. Again, just in terms of housekeeping, let me know if there are any issues with sound, any issues with images. You can drop me into the Q&A or into the chat. And also if there are any issues joining, obviously you can get this on demand again once we have finished today. So you can email Magda and let her know if there are any issues with that. So I want to refer back to last week's webinar. Someone had asked me a question and I had set a reminder in my diary to go through this. Some of the drawings you're about to see were not done by my 2-year-old, even though they look like they were. You can see him struggling with a Magnum yesterday. But someone asked me in relation to a diagrammatic representation of what a pulp burr looks like in a cavity. And I talked about the idea that if you don't stabilize the burr before you take an intraoperative radiograph in order to determine where you are in terms of access, that it can give you the wrong information and ultimately lead to problems. So if you take a look, this is the drawing. You've got your pulp burr stabilized by a cotton pellet. And that is sitting in the depth of the cavity here on the image, and our canal is down here. Now that's an exaggerated access, obviously, but you can see where that burr is sitting, so that when you take your radiograph, it tells you, okay, I'm at 16 millimeters, and 16 millimeters is the depth to which I have already prepared this root canal using a pulp burr. Whereas if you take a radiograph and you don't stabilize the burr, you will see, for example, that you will end up with some space down here. You will take your radiograph and say, okay, my burr is at the full depth of the cavity, because often that radiolucent portion isn't particularly visible on the radiograph that we take. And not only that, but we don't pay attention to it. And often it never ceases to amaze me, and I'll talk about this next week in obturation. Sometimes I take a radiograph and I look at it and I think, okay, yeah, I'm happy with that. And then I'll look at it more closely later. And these are often intraoperative radiographs. And I think, there's something there I'm not quite happy with. So we're often seeing what we want to see. And that has been proven in multiple papers. So it's something to keep in mind when we take a quick glance, particularly at an intraoperative radiograph, and digital radiography lends itself particularly well to, just having a glance as you're working. You've got to make sure that you're paying attention to detail here. But if your burr is in there and you've got space there, you will then incorrectly assume that you've got another, let's say, 2 millimeters before you reach your lateral aspect of the root. And if you don't correct yourself and you keep going, you end up with a perforation. A perforation that, of course, is manageable based on what we've talked about previously, but equally a perforation that you would preferably want to avoid. So today is about speeding up our instrumentation, and I have specifically tried to tailor today's webinar to talk about that, not to talk about the intricacies of glide path preparation, the intricacies of nickel titanium instruments, because I never remember any of that metallurgy stuff, but to talk about tips and tricks that you can use to speed up your instrumentation, communicate with your patients correctly in terms of what you're doing and in terms of explaining when problems arise, because they do. And then develop a system for you that you can take forward and say, okay, I've learned 1 or 2 things that I'm going to implement, because we're doing this all of the time, not at the moment, obviously, but we do a lot of root canal instrumentation, and the instrument does an awful lot of the work for us. So really, it's just about fine tuning that. It's about not really making too many changes. Now, if you look at the images on the screen, and some of you will have seen me show this before, you look at these images and you think those roof fillings look fine, nice taper, densely packed. You can see some different curvatures. And the reason I put them up is to say that it's not necessarily just about the white lines. The instrument has done the majority, if not all, of the work here. And interestingly, every one of these treatments was not successful non-surgically. So as a starting point, we're going to say, let's not focus too much about what the instrumentation ends up looking like when we obturate, but rather what we're doing when we're carrying out the instrumentation, so the cleaning and shaping procedures. So I suppose a starting point would be to consider what the aims of today are. And in keeping with previously, we're going to keep them really simple. So we're going to develop a system, or you're going to take what I'm talking about this morning and you're going to add that to your existing system, chop things off, add things on, but not necessarily change everything that you do. We're going to talk about how to increase speed when we're doing this, primarily because, as we talked about previously, when we emerge from this lockdown, efficiency will be very, very important. And one of the areas that we're slow on is access, but we're also too slow in instrumentation terms. Number one, because I think we're not following exact protocols, me included. And number two, because I think when we're doing it, we're too tentative in terms of making mistakes. And often it's then that you make a mistake, because interestingly, if you take broken instruments as an example, they fracture in two different ways. And one of those ways is cyclic fatigue. So the longer you're in the root canal space, turning that instrument, the more likely you are to damage it or break it. And then we will talk specifically about those different errors. So ledges, transportations, broken instruments, how they might impact on treatment, how we might be able to overcome them, and how significant they are as well in terms of us dealing with our patients and in terms of our overall success versus failure. And I want to start by just going through this again, because we talked about this the last time, and this is really important. So I'm not going to go on about Krasner and Rankoff's paper, but I'm going to say just to remember that those laws state that the root canal orifices are at the junction of the wall and the floor. Okay, that is really, really important, because if we overextend our access cavity out here, getting those instruments in initially is really, really difficult. And we end up essentially trying to compromise in terms of our access and in terms of our coronal instrumentation. And that causes problems for us later. Now, I showed you this video previously, and I want you to specifically focus in on one section of it today. And I will show you where this is. So it's somewhere up around here. And I want you to look at, and hopefully the voiceover will work on this, but I will talk you through it after if it doesn't. But if you look at this, this is me locking a size 10 hand file into a tweezers. And the reason I do that is that it improves visibility. I've got short little fingers. And so when I go to put a file in, especially when I'm looking down the scope or looking down loops, I end up in a position where I can't see exactly where the tip of the instrument is going. Yeah, I can see the head of it because it's in my fingers, but I don't want to see the head of it. So I want to see where the tip of the instrument is going. And also I want you to pay attention to two other things. Number one is, as the size 10 file first goes into the canal, you can see how rigidly it fits in there. I always use a 21mm file because I get way better tactile feedback. So the sponge I have for instrumentation, for most cases, including retreatments, will have a 2110, it will have a 2510, and it will have, for me, an X1 Pro Taper next. Sometimes I may add in a 2-gate Slidden, sometimes, not always. But certainly I want to keep that sponge as minimal as possible, because for me, it just makes the whole thing a little bit more simple. So if you look at this, and we'll see if you can hear this. Okay, so someone has just said there's no sound in the video, so I'm going to talk you through this. And you can see that instrument going in there. Look at the action of my fingers. Gentle watch winding, and then suddenly pulling back out of the canal. You can see, file is bent. That's not a problem. You take it back out. I think actually I readjust this and put it back in. And you don't necessarily have to throw it away. You meet those problems when you do your initial kind of glide path. But for me, the key part of it is actually seeing where that instrument is going. So it slots nicely back in. You can see how hard it is when you can't see. And then you're watch winding, picking. And that's very, very important, because the initial coronal access via a crown down approach, that's the most important part for me, I think, of the instrumentation. Canals narrow anatomically towards the apex. We all agree with that. But the hardest part often, think of a calcified tooth, is just getting in there for the first time. It's getting into the coronal portion. And there's no point in trying to use a step back technique where you work your way right down to the apex with a size 8 or 10, and then you start stepping back up. Do it on the way down. So introduce the size 10 in as far as it will go, a little bit of watch winding, a little bit of pulling back in order to establish a glide path. And there are a million definitions for a glide path that I don't want to talk about this morning. A glide path is just a safety path for the tip of the rotary. Look at it as being as simple as that. You put it in, you watch on, you put plenty of irrigant in, and then you introduce the tip of your rotary just into that little space that you've created. And you repeat that over and over as you go down into the root canal space. Now, it was interesting because you could see on the file that I put in initially, there was just the most subtle of curvatures. And you can see these images. Some of these files are kindly provided by Dentsply, but you can see the images. These are quite pronounced curvatures. But what we have to appreciate is the big difference that is there, essentially between what the kinked file versus the curved file looks like. And if you look at the curvatures in the radiograph that are visible here on this image, they're quite simple to manage. Nice soft curvatures. Nickel titanium loves that type of anatomy. So don't worry in a case like this where we look and we say, according to kind of case difficulty assessment criteria, oh God, the angle of curvature is this. It's not just about that. It's about other things to do with the curvature as well. But as a simple rule that I want you to take away from today, every file you introduce in, so in my case, that's a 21 mil size 10, that should have a very, very subtle curvature in the tip. It doesn't need to be necessarily kinked like that unless you're getting around an obstruction or unless you've got a really acute curvature. But you do need to have maybe something slightly less than the image on the bottom here, but you want to have just a slight curvature. And the reason for that is very simple. Every root canal that you put a file into will have curvatures within it. You might not see them, and you might not even detect them when you put the file in, but if you put a straight file in, you're at risk of damaging that anatomy and blocking yourself or ledging yourself when you do it. And if we look at this radiograph as an example, the distal root of this lower molar, they're the ones that are the most difficult often. And this kind of anatomy is very common in lots of different areas, but I find personally is very common in palatal roots of upper premolars, very common in palatal roots of upper molars, and very common in distal roots of lower molars. And how many times when you're treating those canals, do you instrument them and you say, I'm at a stop, I'm not getting a zero reading on my apex locator. Why am I not getting a zero reading? And you know you're very, very close, both in terms of your radiograph and in terms of your estimated length if you've taken it. But you can't get patency. You can't get the file out through the foramen. And that can be significant, especially in necrotic cases. So at the beginning, you put that little curvature in the file, because I remember Cliff Ruddle at a seminar I was at before talking about the fact that after 2 or 3 passes with a size 10, you're going to start blocking anatomy. And I will show you a little video in a second at the damage that a small file can do. And it's all relative. You know, we're talking about minimal damage. If you're a millimeter away from the foramen and you just can't get patency, the likelihood of your irrigant getting down there and cleaning is very, very high. The likelihood of a successful outcome is very high, but that's not what it's about. It's about simplifying our instrumentation. And there's no surer way to slow down your instrumentation than to have to go correcting your own mistakes. I often find that's the most frustrating thing of all. And of course, there are a million academic ways to assess the curvature of a root canal system. And even this systematic review mentions the fact that there are 11 studies that exclusively use the angle of curvature. So that's our top left image here from a study originally done by Schneider, where they talked about, you know, just the actual angle of the curvature. And that doesn't take into account other things. It doesn't take into account, most importantly, the radius of curvature. But all of this stuff seems a little bit irrelevant to me. And within the systematic review, they actually acknowledge that a huge number of these assessments are only done for academic purposes. And they also reference multiple case difficulty assessment criteria, which I have to say, I am not an enormous fan of. Number one, because of their complexity, and we talked about that in our restorability seminar. So with these indices, do you use them and why don't you? And a lot of people percentage-wise were saying, I'm not aware of them and I find them too complex to use. And the AAE, case difficulty assessment for doing root canal treatment, it takes almost as long as doing the root canal treatment itself to go through the kind of algorithm that they have. And that may not be relevant to you, okay? Because you may be doing a lot of endodontic treatment, you may be doing a lot of endodontic treatment really well. So you don't need to go through all that algorithm. You need to look at a tooth and you need to, I suppose, trust your instinct and say, as I said before in previous seminars, I've done this before. I adopted this strategy. This went wrong, this went right, so I'm going to make some little adjustments. And it's all about that application of your biological and technical principles that helps you. So don't be scared off by people saying, oh, look, it's a 90-degree curvature. It might be a soft 90-degree curvature in a 13-year-old patient that it's very easy to get a size 10 file around, versus you might have much less in terms of an angle of curvature, but in a 90-year-old patient with a heavily calcified root canal system and limited access. And so you can see the scenarios change depending upon a multitude of factors, not just dependent upon what it looks like on a radiograph, which admittedly is a two-dimensional image. And I think one of the keys, and I don't like this term, I don't like the term straight line access, because in essence, we have moved away from this. This is an image that was taken by a colleague of mine, Joe Massey, who's an endodontist down in Bedfordshire. And it's a great image because you look at this and you say, yeah, ignore the fact that obviously you've got a tooth with a huge resorptive defect distally. This was treated in an academic institution as part of a training program. It was for a hemisection of that tooth. But of course I would agree, and I'm sure all of you would agree, this tooth would probably come out today and be replaced, okay? But looking at it, you've got really good positioning of the files. That's what you want. You want them nice and straight. You want to remove the triangle of dentine that sits here, and you do that in a crown down approach. So you get your size 10 file in, you put it on your tweezers, and sometimes in easier canals, I will leave it on the tweezers to do that initial glide path, because in a younger patient with a more patent root canal system, it is easy to do it. In more calcified canals, you can't do that. You'll put it in and the size 10 will kind of lock into position, and then I'll put my fingers on it and slowly start to watch wind. But in an easier canal, or in a, let's say an anterior tooth, you can put it in and keep it on the tweezers and move it up and down. Don't be rough with it, but you can see then where the file is going. And that gives you a massive sense of how much of a glide path you need, how much straight line access you need. And the reason I don't like that straight line access term is it's too much of a blanket term. It's saying, oh, you got to get straight line access for this tooth. You have to get it when you do root canal treatment. That's not true. And straight line access isn't about putting files vertically into canals. It's about getting yourself enough space coronally so that you can safely introduce nickel titanium down here, not transport out here away from the curvature, okay? And not end up with a load of dentine removed from the danger zone of the furcation area here. But straight line access, in essence, as a term, lends itself to us saying, well, I'm just going to take away too much dentine coronally. Now, more commonly, we don't see this. More commonly, what we see clinically when we're treating patients, all of us, is we see something like this. And you put your file in and the file is sticking right out on one side. And this is very, very common. If you think back to what the MB2 looked like earlier, when I put it in on the size 10 file in on the tweezers, the canal is so tortuous and so calcified coronally that when you put that file in, the file is actually referenced at the distal aspect of the tooth. And when you start to do your coronal flare, the file will start to straighten up and become a little bit more vertical, so that ultimately, when you prep an MB1 or 2 in an upper 6, your reference points end up being mesiobuccal cusp tips and mesial marginal ridges. If you compare that against a distobuccal, your reference point is often your mesial aspect of the tooth, because to get straight line access doesn't mean you have to use the distobuccal cusp tip and come in vertically. It just means you got to get straight into the canal to limit the effect of having too many curvatures acting on your instrument. But remember this image and take this away, because this will help you. Number one, because if you see this type of relationship that you can see on the screen, you need to get a little bit more space coronally. You need to put your rotary in, or even a gates if you choose to use it, and you need to start brushing towards this area. You want to stay away from your danger zone, but brush towards here. And don't have your instrument all the way down here. Concentrate on the coronal portion of the canal first. Always small size 10 hand file, re-establishing that you can go a little bit further than where you stop. Okay, always re-establishing. Patency isn't just down here. Patency is a fluid thing that's happening throughout the root canal preparation. So if you can only get to 10 millimeters first, you got to get patent to 11. If you can get to 15, then you got to get patent to 16. And you have to repeat that ability to go a little bit further until you can put a size 10 file just out through the foramen of the tooth. That is really, really important. So in a way, I don't want you to think about patency as an academic thing in order to improve outcome or do various things. I'll tell you what it does later, but I want you to think of it as simply being able to get beyond the point to which you could previously and look at it in those terms. And I think it's really important because when we get down to areas that we can see on this image here, so when we get down here to this little kind of acute curvature, or when we see teeth like these where it's curving one way and then it's curving back another way, it's very, very difficult to negotiate these kind of curvatures if you haven't established patency and if you haven't got adequate coronal flare. And if you look here, this is not a bad job in terms of a root canal treatment. And more importantly, aside from a slight widening of the ligament space at the distal root, that to me looks as though it has been successful based on multiple criteria from multiple papers. Obviously, this tooth is a periapical lesion, but it's just been treated. But one of the difficult areas here, and again, this references back to distal canals in lower molars and palatal canals in upper premolars and molars. Look at where the canal actually is. And you can see that little part that hasn't been negotiated. Sometimes that fills with sealer, which is an indication that you probably have been in there and that you have got some irrigant in there and then some sealer subsequently. But this little portion, if you don't have adequate coronal flare and you haven't got a pre-curved size 10, you won't get beyond it. And you will see that radiographically. You will see canal space, so you know there's a canal there. And then you'll try and pick, and you will spend your time doing that when you could otherwise be moving on and either concentrating on irrigation or simply finishing the case off. And I'll get you to take a look at this and take a look at this image in the context of what we call a restoring force. And a restoring force, if you look at it here, it refers to essentially a mechanical property of a metal or of a material where it wants to return to what you call its equilibrium position. So if you consider putting a slightly curved size 10 hand file into a canal, and if you look at this video, you'll see the instrument starting to negotiate its way down. And what I want you to look at is I want you to look at that instrument as it starts to prepare out here. So it's down there and you can already see it's kind of starting to straighten itself up, and it's not really completely traveling around the curvature here. And within a few turns of this instrument, you can see what it's starting to do. Its restoring force means it's a stainless steel file. It wants to straighten up. And so the more you turn it, the more you start to transport out here, and you potentially zip your foramen, or worse still, you end up with a ledge at somewhere like this point. And so that's important that you keep that in mind, okay? If you've got a stainless steel instrument, they are amazing and essential, despite what some instrument systems will say. They are essential in terms of safely establishing a pathway into which you can put a rotary. But what's really, really important is that you understand these instruments will want to straighten, and they will want to create a canal that is straighter and less respectful of the anatomy that is there. So that really, really is important. So if we look here in terms of patency, then when we do reach the end of that root canal space, is patency important? And again, look at all the academic stuff that's there. So you ask someone in an exam, why do you establish patency? And of course it's important in terms of loss of length, because if you lose your length, it's very hard to get it back. Patency gives you that safety net. It gives you that security that you can say, well, I've got down there once. I can go back down to, for example, 21.5 mil. I'll know my file is through the apex, and I'll reproducibly get back there over and over again. It reduces the chance of transportation. Think back to that video that I just showed you. If you can't get down into that position, the difficulty that you will face is that you will start to transport out on the lateral aspect of the curvature, and then you won't be able to get back down to length. Most importantly, it allows your irrigant to get down there. That really is the critical part, because it is shaping and cleaning. It's not, and some people call it now shaping for cleaning. It really is about the irrigation. Of course, the instruments physically remove things, but it's the antibacterial action of the irrigant that is most important. Some people ask as well when to use stainless steel over night tie. And you know, it's interesting because there's not a lot of literature that talks about this. And for me, there are very few papers that talk about the outcome of nickel titanium versus stainless steel. I'll talk about it in terms of instrument fracture later, but the incidence is quite similar actually. But for me, there is one paper by Petiet, which was done in Canada, which found that using nickel titanium gave you a better outcome in comparison to stainless steel. However, for me, that's one paper in an undergraduate clinic. So is that Is it possible to extrapolate that into our practice? Probably not, because experience levels and everything are very, very different. And I think more importantly for me, what I like about nickel titanium, and it's specifically related to today, is I like the efficiency I get from it. It's way easier to create some coronal flare, to create some straight line access, for want of a better phrase, using a nickel titanium instrument. Use your stainless steel for your glide path, but your nickel titanium for your instrumentation, because it's more efficient. It certainly is a little bit safer. And I think just in an overall sense, it improves our efficiency in terms of the whole treatment procedure, not just because of the speed, but because of the shape it creates, which lends itself very well to irrigation and also to obturation. For anterior teeth, I don't know that you need nickel titanium. It breaks my heart sometimes when I take out a series of instruments and I'm doing a central incisor and I put them in and I'm getting to my X5 and I'm thinking, this thing hasn't even touched the sides. And there's 70 pounds worth of instruments sitting in the sponge. So our assessment of that actually for me is way more important than case difficulty assessment criteria and saying, oh God, there's a big angular curvature, this is going to be really difficult. Much more important to eyeball a tooth radiographically and say, I think I'll go straight to stainless steel here. And I'll start off maybe with a size 20, establish length. And then what I'll do is I will go in and I will just instrument by stainless steel. But generally speaking, for any kind of premolars and molars, I think probably nickel titanium would be the way to go. The other thing in terms of patency is it allows your irrigation down into the apical portion of the tooth. And that is critical. And you know, when I said that if you can't get patency, but you're very, very close, remember, I think part of the point of these webinars is to say to you, and I've said this, and this has been, I think, consistent throughout, don't beat yourself up over saying, well, I couldn't get patency there. If you're very, very close, understand that the irrigant will diffuse down there. And take away from these webinars that there are biologically important factors, and that's how you communicate to your patients from now on. That you don't say to them, well, we couldn't get right where we wanted to go. As a patient, if someone says that to me, I'm thinking, what does that mean? That's bad, no? Whereas if you explain to someone, ideally, as you can see in the other canals, to give it context, where you can see that we're right down at this area, and in this tooth, in this canal rather, it looks ever so slightly different. And that's very likely to not have an effect on the outcome. But that explains why the tooth looks a little bit different in that area to the other areas, because you may have an inquisitive patient who asks you. But it doesn't mean if you don't get patency, in certain cases, that your treatment won't be successful. So don't say to a patient, I'm sure it'll be fine, or it may not work, because you want to explain it in better terms than that and communicate in a better fashion. I think what is important in relation to instrumentation, and this is in multiple outcome studies, it talks about the fact that you need to be within 2 millimeters of the radiographic apex. Now, we'll talk about apex locators later. That's not for me particularly relevant. We know where the end is, so we should get there. And we should take 0.5 millimeter off that and work our way down and prepare it. Some people have tried to put numerical values on failure rates if you're, let's say, 1 millimeter short. And Chugall's paper talks about it being 13% lower. But that's a very difficult thing to do, to apply a mathematical calculation to a human being. It's dependent on a multitude of factors. And you saw those images that I showed you at the beginning. Patent, nice obturation, right down to length, and the treatment's failed. So again, I don't think it's specifically important. What I would take from it, if you look at Nagishi's paper, is teeth are more likely to fail if you don't access the apical constriction based on this study. But what they're saying is that particularly in necrotic cases, you want to get right down into that area and clean out those bacteria. So don't apply a blanket rule and say, oh God, I'm 1 millimeter short, it'll be 13% less success. It's not particularly relevant. NiTi instruments help us, remember, because they give us the coronal flare that allows the stainless steel instrument to work freely. If you bind a stainless steel instrument in and you try to negotiate really complex curvatures so that the full length of the instrument is stuck in the canal, that instrument isn't free apically to do what it needs to do. What happens is it's stuck everywhere in the canal. And as a result of that, due to its restoring force, it's trying to straighten up, and then that will block yourself out apically. So really pay attention to that. Patency should never be achieved. Working length should never be determined until you have got an adequate coronal space to, number one, biologically get irrigant into, and number two, have technically removed the coronal interference to allow the instrument to work apically. And of course, if you look at lots of literature, and a lot of it is anecdotal, and you see this on kind of, I don't know if you go on endo forums as often as I do, but a lot of it kind of talks about, oh, you can't get patency, patient will have pain afterwards. And actually, if you look at the study on top by Arias, they looked at 300 teeth, and they got patency in using a size 10 hand file in 50% of those teeth. And actually, in non-vital teeth, there was less post-operative or post-endodontic pain, they call it, in non-vital teeth when they established patency. And the other thing they took out of it, and this again comes back to communication with your patient. This is very important. They found that teeth that had previous episodes of pain were more likely to be painful afterwards. And that's how you should explain it to a patient. I never consent a patient and say to them, oh yeah, it's going to be fine, it won't be painful, because so few patients come back to me and say that they've had absolutely no discomfort, that I just think it would be right not to consent them and explain that to them. But if a patient is in pain beforehand, and particularly teeth with irreversible pulpitis or vital teeth, they often end up with some prolonged symptoms afterwards. There's nothing wrong necessarily. The pain isn't at a level that's disrupting sleep or is causing severe problems. It's not of high intensity, but it's there, and it's enough for a patient to say, it just doesn't feel right. And interesting, if you look at the other paper on the bottom, that's quite a, I suppose, a famous paper in endo terms, and it talks about establishing patency in vital teeth. And this is what I want you again to take away. If you look at the outcome literature, you would say, oh, I'm within 2 millimeters of the apex, so therefore it must be a successful outcome. And then the treatment doesn't work, and we're kind of thinking, oh God, how am I going to explain this to the patient? But look at this comparison. Non-vital teeth, establish patency, and you'll get less pain, okay? You'll get better outcome. We know that biologically. It's intuitive and it makes sense. But in vital teeth, actually what they found, that even when they got patency, these are teeth that had vital pulp stumps at the apex. The outcome wasn't in fact better. It wasn't better. But that doesn't mean that you take away from that, oh, well, I'll never establish patency. What you think about is you think about it in common sense terms, and you say, if you are treating a tooth with an irreversible pulpitis, and you are working down in the apical region, you don't need to keep re-establishing with a size 10 file that I'm right down at working length, because what you're doing is you're pushing that file into the remaining pulp stump. And then as a result of that, you can end up with patients who develop what's called persistent dentoalveolar pain syndrome, where they have that funny sensation from a tooth. So in vital cases, you don't have to consistently re-establish it as often as you would in a necrotic case. For me, I would use it to establish length, no question. And for me as well, one of the take-homes I would say for these vital teeth with irreversible pulpitis, although the literature will tell you, well, 99% of these teeth are successful potentially, I find if they're done in a single visit, patients, anecdotally this is, and it's just my opinion, patients tend to experience more discomfort and prolonged discomfort afterwards. So sometimes it may be worth dressing these teeth and coming back to it later. And of course, there may also be the time factor to take into account, in that you may be treating these patients as emergencies. And in that situation, you may not have time to finish the treatment anyway. So if we look at the situation here, you can see this is what I mean by establishing patency. It's these little areas that are difficult to negotiate into. Right down here where you get two canals joining and then a little kind of a curvature afterwards. You look at a situation like this where you've got a palatal root of an upper molar with that kind of lateral exit point. You look at a situation like this where you've got a premolar, the canals are joining, and you can see the little sealer puff because I've established patency there. Now, sealer puffs are not necessarily needed. You don't have to see a sealer puff. We don't live in the States where they're a desirable outcome because it shows that you have established patency. I trust you guys are using an apex locator. It's telling you whether you established patency or not. But these images show these little areas, and you can see again the distal root of this lower molar. You can see just to establish patency, sometimes you have to put that file through in order to just establish that glide path and allow the file to reproducibly go there. Because how many times do you instrument a canal where you get a size 10 in, and then you're instrumenting, and you go to put the rotary in, and if you've created a little ledge, the size 10 will go and the 15 will go, but the rotary won't go. And there are some ways around that, okay? I'm sure the manufacturers wouldn't be too happy, but you can put a little bend in the tip of your rotary file. And some people will say, well, you can't, might you not break it? And I say, of course it increases the risk of fracture if you permanently deform a material that isn't meant to be deformed. But there's a big margin of error there. And sometimes you got to get around a little edge. You got to get around a curvature. So don't be afraid to put a little bend in a nickel titanium instrument. Don't be afraid as well. Now, it doesn't really particularly work with Pro Taper Next or the reciprocating instruments, but those of continuous rotation. Don't be afraid to put a bend in and put that instrument in on your fingers and give it a little twist. Because remember, if you have a ledge and you get around it with a size 10, a rotary is much, much more tapered. And so because it's more rigid, it doesn't want to go around it. But if you get it around it and you start to turn it, it will remove that ledge much, much more readily than a narrow little size 10. And I will talk about that in a bit more detail when we specifically deal with ledges. But play around with that. Think about it. We're all people who are good at problem solving because we have to do it all day long in our practice. So problem solve it when it comes there. Don't let the wave of kind of, panic wash over us that we always get, when you break an instrument or maybe when you perforate, you kind of think, oh my God, and you get that horrible feeling. It's about crisis management, and everything is relative, and we have a better sense of perspective in terms of crisis management, I think, than we've ever had. But it's really, really important that you just say, well, how am I going to overcome it? And how am I going to overcome it quickly? What can I use that I've got here in my instrument set that will help me to overcome this problem? And ledges primarily occur because we're being too forceful. I think that's the main problem. And it's a recognition that we're pushing instruments into areas when the tooth is telling us, and think back to Krasner and Rankov, think back to what we talked about in terms of restorability. There's a map. The tooth is actually communicating with you when you're doing this. It's saying, okay, stop doing that. And for some reason, we all have this thing on a voice in our shoulder that will say, give it another push, it'll be fine. Just a tiny bit more, you get there. And we don't, and we make it worse. And when you think about that stainless steel instrument rotating, and when you look at it, only a few turns will create a problem, a few turns. So don't think, oh, it's only a small file, because you will be kicking yourself when you're trying to correct it later. Stainless steel is more likely to cause problems because it's got that restoring force. It's not a material like nickel titanium. It doesn't have the same properties, but we do need to use it because you've got to establish a glide path with a stainless steel file. For me, 21 mil size 10, 25 mil size 10. They will go into canals, albeit some canals at a very limited distance, but they will go in. It reduces complexity in terms of your setup. It increases monotony in terms of using the same system, and it will improve your efficiency long term. Get rid of the size 6s to negotiate canals in molars, because you should only be using them, I would say, in about 1 in maybe 30 or 40 cases. They shouldn't be introduced routinely into teeth, because you will ultimately have to get at least a size 10 to establish a glide path, at least, maybe higher. And of course, the main effect in terms of ledges is the effect on our practice is that they take ages to resolve the issue, and ultimately may end up with a catastrophic transportation or an apical perforation. So if you look at this, when your ledge is established here, this is the area here in the image at the bottom that I'm talking about where you can pre-curve a nickel titanium instrument. So you need more straight line access here because this instrument is hitting this portion of the tooth. You would then pre-bend your nickel titanium slightly, and you would pop that nickel titanium file in, give it a few turns, and it will remove this area here. Now then you may look at your end result and say, wow, it's not as nice, that curvature is kind of straightened, but so what? It's better than not getting down there. And what effect will that have on the outcome? Think back to the other webinar, Rhee and Messer. How much does the endodontic procedure reduce the stiffness of the tooth? About 5%. How much does an MOD? 62%. Don't beat yourself up over the tiny, small stuff. Try and accept that it's happened, get around it, establish patency, and get the job done. That, I think, is the most important thing, because the vast majority of these cases where you can overcome the problem and access the apex, they will end up with successful outcomes. We know that from the literature. And then if we look at blocked canals, these are a very, very different entity, because the feeling from a blocked canal is completely different. Because if you look at ledges, often what it will feel like is it will feel like if you were to kind of kick your foot against a skirting board. And sometimes when I'm supervising clinics, someone will say, I think this canal is a ledge, let me have a look. And one of the really good questions that was asked last week about MV2 was, how long do you look for a canal before you stop? And equally, how long do you try to unblock a canal? How long do you try to get past a ledge? And for me, the key take-home message for this today is, if you're getting no feedback from the tooth, i.e., in a blocked canal, when you negotiate in with a file, it will catch ever so slightly. Now that might be minimal. And it might be that after a turn, it feels loose again. You put irrigant in, and always, always, always flooding lots of irrigant in, especially in the block canal. And I love these instruments. These, you can see the graphic on the screen. It's a C pilot file from QED. They are great. And there are competitor files in terms of unblocking canals, but these are amazing. Really, really good. Really, really rigid to the degree that they feel very, very safe. The handle feels nice, and they're the kind of things that I want. You know, I'm not worried about what the packet looks like because the files are in the sponge by the time I get in. And I'm not worried necessarily about, you know, the cyclic fatigue. I'm worried about what it feels like when it's in my fingers. And I'm worried about how well I operate with that file. And I love this instrument, and I would certainly recommend giving it a go. And when you feel a blocked canal, these files are great for giving you that feedback. So you feel that little catch. So if I feel that little catch, it could take me 40 minutes to unblock it. So I'm saying, okay, I'm troubleshooting here. I found the problem. Now I need to overcome it. And it is an aggressive action. It is a picking. And sometimes you've got to take that instrument out and take a quick look down the microscope. That is important. Don't be shocked by an instrument breaking if somewhere in your mind you're thinking, wow, I'm working this instrument really hard. It probably might break. But again, I refer you back to the biological aspect here. If you feel as though, for example, in a necrotic case, where we know patency is very important, or a retreatment case with a periapical radiolucency, if you feel like you've got to get there, then you've got to get there. You've got to get there, and you've got to unblock that apical portion. And then you're picking. But if a canal feels blocked or ledged, and I put an instrument in and I can't find a point where it will engage, or if I'm pre-bending or kinking a file, like the image earlier when you could see the file going down, and I'll see if this will work. So when the file goes down and you're trying to negotiate past the ledge and you've put a little kink in it and you can't get it to engage beyond that ledge, so this specific area, you've got to give up at some point. There's no point in banging your head off a brick wall. And what you refer back to is you refer back to what I spoke about in previous seminars. You refer back to the retrievability, and you refer back to your communication with your patient, okay? You don't say to them, look, I've tried and I can't do it and it probably won't work. You say to them, we have used the techniques that are recommended to do this, and there is nothing evident that seems that we're going to be able to get beyond this little blockage or this little ledge. However, we're very close to the root end. We have put lots of disinfecting solution in, and I feel that it may be worth filling this tooth, reassessing you 6 or 12 months later. And if there are issues, we will talk about other ways to try and overcome it. Number one being maybe being a little bit more aggressive in terms of your instrumentation, or number two, potentially referring the patient for surgery or doing it yourself. Someone is asking just what's the name of the graphic up here. This is a C pilot file from QED. And again, I only get these in a size 10. I don't get them. They come in loads of different sizes because for me, a size 6 is too small. Size 8 can be useful sometimes, but if you're going to get there, you're going to get there with a size 10. Again, another take-home message from today. Very, very important, because if I'm using a size 8 coupled with a more aggressive action, I am then worried potentially that I'm going to break the tip off that. And that has happened to me multiple times. And what do? I explain it to the patient and I try and negotiate past it, because the goal never changed. If I break the tip off an instrument because I am being, in essence, overly aggressive with that instrument, I still got to get there, and I still have to start picking my way down towards the apex of that tooth. And that is really, really important. And then I refer you back again to, and again, this is why I kind of wanted to, I don't want to talk too much about this generic stuff to do with, I suppose, this is how you instrument, you create a glide pad. I'm talking about what happens to you in practice. But you've got to remember then, you go in at your size 10, you establish your glide pad in that up and down motion, like you could see when I was watch winding first in the MB2, but then filing up and down. Some people use this image in the middle, these kind of automatic or rotary glide pad preparation files. For me, in general practice, it's too expensive. I think you cannot justify spending 12 or 13 quid on a rotary glide pad preparation file when the other instrument will do the job. And then you introduce your rotary in, and you, of course, sequentially do that. These images sometimes, and this is part of the problem, I think, with, I suppose, descriptions of how to instrument root canals, every one of them will show you the instrument at the apex. And they'll never tell you how to get there. And they're like, all you got to do is this. No, this is the critical part up here. This is the critical part with the rotary. And I would probably want a little bit more Again, straight line access in inverted commas at this point. So my instrument was maybe sitting a little bit here, depending, of course, upon the case. Because remember that the nickel titanium instruments are massively forgiving. So you could really put one in with very limited coronal access, but why would you? Because you're potentially introducing problems for yourself. And so then we do all that and we get our apex locator out. And, you know, I think sometimes in endodontic lectures, people are too flippant about the use of apex locators. And they will talk about, someone has asked me as well, do I ever use ProGlider files? And I've just referenced that. I use them a little bit, not an enormous amount. And I do use them in kind of the more complex curvatures. But again, in terms of the setup for me, it's not an instrument I routinely put into my sponge. I have my 2110, my 2510, and for me personally, I have an X1 ProTaper Next. And I think, again, another take-home message for today is, you know, I think a load of us over the last few weeks have been removing clutter from our houses. Well, remove clutter from your endodontic sponge and from just your dental practice in general, I think. You know, you don't need to, as I said before, endo lends itself so well to all these massive gadgets and all these crazy things that supposedly help us. But it's about paring it back and getting it down to, okay, what do I actually need? And then you can make your add-ons later. And who knows, you know, you might pare it all back and in 18 months say, nah, I've got all that stuff back again. Whatever works for you. But for me, I would keep it really simple. And so, yeah, as I said, sometimes you go to lectures and people will kind of flippantly talk about apex locators and they say, oh yeah, you just get your apex locator. And I remember using apex locators before I trained, and I would use them and I would think, this thing doesn't bloody work. And sometimes I go on clinic and someone will say, I can't get a length. And I will go down and I'll say, okay, yeah, so it's for this reason. But it's too easy to say, oh, you have to have an apex locator and you have to use it, and otherwise you won't be able to determine length. If it doesn't work properly and it doesn't give you the information you need, it's bloody useless. That's the problem. And I refer back to when we looked at assessment of restorability to try and keep this a bit consistent for you, so you remember these messages, not just in relation to I have a message for restorability and a message for this and a message for this, but I talked about it being a crime scene. And I talked about the idea that what we would have is we would go back to the scene of the crime. So there was something that was there when we assessed it first, there was something we did when we looked through it, and then there was something that we missed. And so in relation to apex locators, there are things that are there that will mess it up. Okay, number one, metal restorations, any kind of metal. It might be a ceramic crown, but there might be some kind of amalgam core underneath it, or it might even be a tiny little pin in a composite. And you're saying to yourself, this isn't working, I can't do it. Don't then fall back on, I know what I'll do, I'll take a radiograph. If you don't think you're close to the end of the root canal system, and if you don't think you're going to get information, don't take a radiograph. You don't take a radiograph to check, to see something. You take a radiograph in endodontics to confirm something. So don't take radiographs just because you think, oh, look, I'm at C here, I'll take a radiograph and see where I am. You know where you are. Measure the tooth on the radiograph preoperatively. Establish where you are by pushing the stopper to the reference point. That'll tell you where you are. Sometimes we do that, and I do that as well, because it's a security. It's to say, okay, it's better than I thought. But then sometimes it's worse than we thought as well. I'm sure if you did a study on it, it'd be probably 50-50. So don't do that, okay? But something that was there might be affecting you. Equally, when you get into the root canal system, it may be that there's too much fluid in the chamber. People often say to me, how much fluid should be in there? And again, no one tells you this in lectures. They just say apex locators are 96% accurate, and they work by, establishing the difference in electrical impedance between the PDL and the tooth itself. And I'm like, I don't even know what that means. But more importantly, you put too much irrigant in, it'll bottom out straight away. So for me, you need no irrigant in the pulp chamber, but the canals need to have some fluid in them. If it's not working when you have fluid in them, put a single paper point, a matched one, now a tapered paper point, into each of the canals and remove some of that excess irrigant. I find that quite useful, but don't use them dry. Don't use an apex locator with dry canals. It may also be that you've got some tissue in the tooth, and that's quite common in vital teeth, something that was there already, so a piece of tissue down apically, and it's just for some reason the apex locator is bottoming out. Again, if you can't establish length, that's a classic example of the tooth telling you, pack it up for today. Put a little bit of dressing material in, come back to it. And I will often do that, because if it is a piece of tissue or some fluid draining through the tooth, you're not going to be able to finish the tooth anyway. And if you do, you're just robbing Peter to pay Paul, and you're going to create problems in terms of your outcome afterwards. It might be something that you did. It might be a little perforation, and not a perforation in the pulp chamber floor. It might be maybe that you were a bit overly aggressive with your coronal flare and you strip perfed the furcal area. So keep an eye on that as well. It might be something that you have done, okay? Or it might be something similar to a little piece of amalgam. How often have you seen this happen? I would say this has happened to every single person listening today, and me too. You look at a radiograph and you're like, that's a piece of amalgam from the core, and it just works its way in. How, you don't know. And the weird thing is sometimes it will be working itself right around the canal and you can even see it, but you can't get it out, but that'll bottom out your apex locator. Or it might be something that you missed. It might be something like a crack in a tooth, and it would want to be pretty substantial, to be fair, to affect an apex locator. It might be an extra canal that you haven't seen, and then you're putting the file in, even though you've prepped, for example, one distal canal, you keep getting it into the other one, the little small one that's unprepared, with a load of fluid and a load of tissue in there, and that's bottoming out. Or most importantly, it might be that the batteries aren't charged or the battery power is gone on the apex locator. That's something we miss all the time. I'm looking and I'm hearing beep, 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 and I'm thinking, why is this thing not working? And I look and I'm saying, the batteries are gone, and that it won't work properly. It won't work properly. And they're the little things that I want you to remember. You can't control cracks in teeth. Sometimes we can't control when we do a little furcal perforation. I remember I treated a tooth when I worked in Australia. It was a broken instrument case, and I went in a lower 6 and I instrumented all the canals, got patency, got around the instrument. I was so happy. And when I took my length, absolutely fine, dried the tooth off. When I obturated the tooth and I was using my obtura and backfilling, I was thinking in my own mind, you know, it's like the penny is kind of dropping and the light bulb is coming on. This is taking an awful lot of GP to fill. And I kept pulling and pulling and pulling. And it's almost like the message to my hand took longer to get there than my brain was telling me. And I realized, hang on a second, what had happened was there was a tiny strip perforation and you put GP out through that perforation. So it had to be surgically removed, and it was successful in the end. But that feeling when you realize what's going on is not a nice feeling. But that's something that you miss. Sometimes those little perforations are very hard to identify. So with your apex locator, control what you can control. Know how it works, okay? It's only accurate when you get down to that 0 reading, okay? Those numbers, they mean nothing. They mean nothing. When you are in all of the green lines, so the bit very close to the red, you are very close to the constriction based on the evidence I have read. But the 3, 2, 1, that means nothing in terms of your function. Control that. Know that an apex locator, it should gradually go down. If suddenly you put the file in and it goes beep and you're right there, no, you got to check that again, and you got to establish patency. So you got to go through, bring it back, through, bring it back into the lines of the red, okay? And then make sure the batteries are there. Make sure that the thing is fully charged so that when you're using it, it's going to work properly. And then the other things maybe potentially are not under your control. So you might find yourself, for example, saying, I've done all the things right and I'm not getting successful readings here. As I said, call it a day. Stop. Put a dressing in, dry the tooth up, and you will come back to it and you will find that easier. I don't have a particular preference in terms of which apex locator I would recommend. I think what's, for me, I like the Root ZX, and I try not to plug too many products on these webinars because I don't necessarily think that if I tell you to use something, you should use it. I love the Root ZX, and for me as well, the good thing about it is it's indestructible. And you know, it's funny because sometimes in the practice, I hope Kevin's not listening, but you know, if a piece of instrument would be dropped, and if the apex locator is dropped, there's like that kind of, there's kind of a shock, you know, where everybody looks and goes, oh, an intake of breath and going, oh my God, is the apex locator broken? But the Root ZX seems to be indestructible to me. Sometimes I do feel like firing it against the wall when it's not working, but I'm sure if I did, it probably would work afterwards anyway. So I love the Root ZX. I think sometimes some alternative apex locators are dressed up very nicely and they look really fancy, but I like the Root ZX. Very simple display, very easy to put the batteries into, and for me, it works really well. Be careful as well because it lasts for an eternity, which means that sometimes the wires tend to not work as well and the hooks don't fit as well from just wear and tear going in and out. So they're the things you might need to replace. But the unit itself, although expensive, it's a great apex locator. And of course, in terms of root canal and cleaning and shaping, the most important part, as I said, is the cleaning part. And I show you this image. This is from Ove Peters' study where he looked at the amount of a root canal space that you instrument with nickel titanium. And we're obsessed with the white lines. And we're even more obsessed when there's a broken instrument contained within the white lines. But look how much of the root canal system was instrumented. That's the green part. Okay, so you can see you can imagine what that would look like on a radiograph. Oh, a lovely shape, and yeah, beautiful. You would see a little bit of GP down here, and you're right down at length. Look at all the part that wasn't prepared, all the red. So for me, we're not preparing huge percentages of the root canal system. And this is where four-handed dentistry, and again, I'm not going to talk to you about anastomoses and bacterial biofilm. How is that going to change your clinical practice? Are you going to go in and say, I wonder now, have I reduced the bacterial load down to a critical level which is compatible with healing? No, you're not. You're going to say, if you instrument a tooth like this one, and if you can look at what that green looks like on a radiograph on a cone fit, for example, you're going to say, oh my God, that looks amazing. I'm delighted. You're not going to think about the red. But what we need to do in the back of our mind is think about what this red signifies. But how does it apply to what you do in practice? For me, it means you should be spending as much time irrigating as possible. So you should be allowing your nurse to do everything else that is legally permissible in terms of what they can do in their role as a dental nurse. So in terms of the setup, get them to set everything up, get your sponge ready. You don't want to be taking things out of packets, because as dentists, and I know all of you are nodding when you're going to hear this, when something isn't going well and we're saying, I need another size 10, and our nurse can't get the packet open, we're getting angry because they can't get the packet open, even though those packets are incredibly difficult to get open. And they're feeling the pressure as well. And the most important thing is the patient's feeling the pressure. They're feeling your anger at your nurse. Your nurse is feeling under pressure because they can't open the packet. And all because instead of saying, that's okay, take an additional 15 seconds to open the packet, and I'll just do a little bit of irrigation. And that's what's important. You can hold the suction tip yourself. I don't know what that will mean going forward, but you're not generating an aerosol when you're irrigating. Get as much hypo in as you can. You're not going to do damage putting hypochlorite into a tooth. So that's important. And equally, don't be a control freak. My nurse measures an awful lot of my instruments for me, not the hand files. And sometimes I recheck them. And sometimes I can look at an instrument and say, that's incorrectly measured. And it's a relationship, and it's a technique we've developed over time. If you have a brand new dental nurse, I wouldn't say, measure these, and then you're looking going, well, that's wrong. And equally, you have to pay attention to the smaller instrument sizes. So the early shapers are going to have narrow little tips. So they're more likely to bend and be inaccurate. But the finishing files are big, broad instruments, 25, 30, 35, whatever system you're using. They're very easy to manage in a block. So you focus on the biological part, and your nurse is in control in terms of that four-handed dentistry approach. You don't have to be a control freak and control it all. Because if you look at what this looks like, and I'll try and speed this up, this is full strength NaOCl. So depending on what you're using in practice, full strength 5%, people use 3%, and I'll talk about some literature in relation to it later that quite surprised me when I researched for this webinar. But you can see this is a piece of tissue in there, and basically you all know what's going to happen. You can see it starting to break down in the full strength, but taking much longer in the other one. And then suddenly, with a little bit of agitation, you can see how much this tissue is starting to break down. It's dissolving, okay? And it's disappearing. And that, for me, is the main reason you want loads of hypo in there. You want to keep replenishing and replenishing and replenishing. And a lot of this comes from a study done many, many years ago by Moorer and Wesselink, which talks about essentially the tissue dissolution capability of sodium hypochlorite. Now, some take-home messages for you in terms of this. Number one, EDTA reduces the tissue dissolving capability of hypo. So don't use EDTA throughout the treatment procedure, because number one, you don't need to. Number two, it adds complexity in terms of the setup that I talked about with your nurse. And number three, a paper in 2003 found that it limits the tissue dissolution capability. So what you are doing is you're saying, well, look, EDTA removes the smear layer, so I'll keep using EDTA, but I will then compromise my primary outcome, which is, in lots of cases, getting the hypo in, killing bacteria, but dissolving tissue as well. Necrotic tissue will not cause apical periodontitis. That has been definitively proven many, many years ago. But necrotic tissue may potentially end up as a source of nutrition for residual bacteria remaining in the root canal system when we finish treatment, okay? And I think it's not going to sit within your root filling. It'll sit in the red uninstrumented areas. And all teeth after root canal treatment, or nearly all teeth, will have bacteria remaining. And the percentages remaining are vast. I'll talk about it later. But don't think your canals are disinfected, because they're not. But the important things that Moorer and Wesselink found, where they found that the amount of organic matter is important. So the more tissue you have in, the more time you have to spend dissolving it. So vital cases, let the tooth soak. Importantly as well, the frequency of agitation and the intensity of the agitation was important. So agitate your irrigant. You don't need to go out and buy a fancy ultrasonic. Use a GP comb. Agitate it. Get it into the red areas from Ove Peters' study. And finally, the surface area of the tissue as well. Okay. Someone has asked as well in terms of glide. And it's a really good question, very topical question, because I've said don't use EDTA. I wouldn't have an objection to using glide, although personally, I find that, again, to try and keep it on the kind of theme of, you know, trying to what's valuable for practice, I hate the way it creates loads of bubbles and I then can't get the instrument into the canal. But glide I would have no objection to using, because you're talking about using it in relatively small amounts and you're in comparison to using a whole load of hypo, whereas if you're irrigating, you're getting more of that EDTA in. For me, I think the hypochlorite provides enough lubrication for my instrument. I don't routinely use glide. And actually, I tend to use glide more often on hand files when I initially negotiate in there. Because what happens often, and I find this is more common in vital cases, I put a hand file in and I negotiate down. And I can get the file down once and then I take it back out and I'm like, okay, I'll go back in. And even though it's a case where I'm saying, hang on a sec, I haven't blocked this canal, I can't get the file back down to length. And often what happens is you're plugging pulp tissue into the apex, and pulp tissue is protein, collagen. So when you push it together, you make it really, really hard. If you put glide on the tip of the file, the glide will allow you to get back into that space again, because it stops the tissue from kind of sucking back together into that area. So I do use it on my hand files, not routinely on rotaries, but the short answer is I would have no objection. I would be out on a limb here saying don't use glide in your rotaries because it's an internationally accepted protocol. And then I think one of the things that we worry about a lot during our irrigation is, you know, are we going to extrude it? And again, this is like perforation and instrument fracture. We go over the top on this, okay? Because we get freaked out that this is going to happen to us, and probably minimal amounts go out in all the treatments we carry out. Christos Boutsiakis has looked at this. He's done some amazing studies out of Amsterdam, and he's a Greek dentist. And he took the important things he took away. This is a very academic study, and he talks about the idea that there's a lot of non-standardized reporting of this stuff. But what can you take away from this for your practice? Number one, 85% of these problems were occurring in the maxilla. So if you're doing a maxillary tooth, I'm not saying to yourself, this potentially happens anecdotally once in a career, okay? So you're not going in every time going, I don't want to have a hypo accident. And if it happened to you 6 weeks ago, of course, the next 6 weeks are going to be tough. But think, I'm in the maxilla, it's more likely to happen. A lot of it is related to anatomy and technical factors. So what did the apex look like? Was there a long-standing periapical radiolucency? Because that creates resorption around the root tip. We know that. Or was it something I did? Did I go through the apex? Did I lose my finger rest? And did you get that sensation where the rotary sucked you into the tooth and you've increased the size of the foramen? So all those things in your mind, if you do that in an upper premolar, for example, you're thinking, hang on a sec, 85% of these occur in the maxilla. I need to be a little bit careful here. And remember what I said earlier, irrigant is liquid, hypochlorite. It will diffuse down there. This idea that you have to be 1 millimeter away from the apex is reported in some studies, and some studies say you've got to be 2 millimeters away. You've got to gauge it according to how you can safely irrigate and not bind that canal in there. And the other thing that Boutsiakis talked about was he talked about the flow rate of the irrigant, which is really important. Some people, when I watch them when I'm supervising the clinic, so much irrigant is coming out. You got to use your finger as well, not your thumb, to push the irrigant out. That's not safe. You'll push too much of it out. And if it goes wrong, which it probably won't, you're putting a whole load of irrigant out there. And the more you put out there, the more intense the inflammatory reaction will be afterwards. So you've got to be careful. Someone has asked as well what my preferred file measuring instrument is as such. I love the blocks that Dentsply provide. I just really like them because I can say to my nurse, okay, that's 21. And my nurse is measuring, if it's moving quickly, my nurse is measuring the instruments for the other canals in a multi-rooted tooth while I'm instrumenting, say a palatal canal, I'll get to X3 and my nurse has measured X1 and X2 for the next canal. And then she will say to me, mesiobuccal 1. And then I'm instrumenting. And that's the type of workflow that I'm talking about. It's not me saying, okay, let's spend a couple of minutes like waiting for everything to be measured. My nurse will say, you're doing the mesiobuccal next. And I like that guidance because that means then that I'm concentrating on what I need to do. And I think as well, we then need to consider what type of irrigant we're going to use. And this is really, really important. And we use hypochlorite routinely. And in terms of where we put our irrigation needle, the most important things are not necessarily the depth to which you put it, but an understanding that you've got to do it safely. The needle cannot bind. And in a curved canal, for example, if you can't get the irrigant down to, let's say, the apical third of that tooth, which was reported in an editorial in the International Endodontic Journal as being a sensible area to irrigate in, if you can't get it down, you've got to activate the irrigant. Use a GP cone, a matched GP cone, put some irrigant in, pump it up and down, and it will push the irrigant apically and it will push it laterally into the red uninstrumented areas, and that will improve your efficacy. But just be careful in terms of where it goes. Now, there's been an awful lot of talk about hypochlorite versus chlorhexidine. One thing I want you to take away is that you do not use hypochlorite and chlorhexidine together. Number one, because they cause a toxic precipitate in the root canal system. People say that's carcinogenic, but they also say that all the household stuff that we clean our houses with is carcinogenic, and we're all cleaning our houses like crazy at the moment. So for me, that doesn't particularly apply because I don't know the significance it holds on an individual or on a population level. But number two, a study has found that if you use chlorhexidine in combination with hypo, the outcome of the treatment is not as successful. Now, that may be that you're throwing everything at that tooth and it wouldn't have been successful anyway, but that's important. If you look at some of these studies, if you look at Isabella Rojas's study, the one in the middle that's kind of covered, she compared 2% chlorhexidine versus 2.5% hypo. Now, importantly, she compared 2% chlorhexidine, not corsetal, not a 0.12 or a 0.2, at 2%. And that stuff actually isn't easy to get routinely. But more important than that, when she found that the efficacy of the two of them was the same, and this is a randomized control trial as such, she found that the disinfecting effects were the same. But that, and I said this earlier, 40%, roughly speaking, of the teeth had residual bacteria. These are single-rooted teeth. We think we clean them really well, but 40% of them had residual bacteria. But the more important thing to take away here is these were single-rooted teeth. They are easier to clean, despite the fact that there were multiple teeth with bacteria that were left in them, and up to 40%. And I think what was important as well is how they looked at the residual bacteria. It's using a PCR technique, so some of those bacteria may be dead. But for me, I'm not going to say this study is good or bad, one way or the other. What I'm going to tell you is chlorhexidine won't dissolve tissue. And in a lot of the cases you're treating, and again, to keep this relevant, when we go back, and you're going to see patients who have had an irreversible pulpitis, and I'm hoping, based on what we're hearing currently, that the time won't be too great before we go back into practice, and these will be priority patients. And biologically, there won't have been enough time for these teeth to become completely necrotic, so these teeth will have some tissue in them, the worst of both worlds for you and your patient. Chlorhexidine isn't going to dissolve tissue in the root canal system of those teeth. And one of the positive things to come away from this is that we're going to be using rubber dam for a lot more situations. And if you're using rubber dam, you might as well use hypo. Because if you're using hypo and if you're activating hypo, and you remember the image on the left from last week, but you can see the intricacy of these root canal systems. There is nothing wrong with the root canal fillings in these other teeth, here and here, but they are not a true representation of what the root canal system of those teeth looks like. The root canal system of those teeth is probably very, very complex, and it's not as complex as this or this, but you're going to end up with multiple areas that need to be reached by your irrigant. And to reach it with your irrigant, you've got to push it in there laterally. And I'm not going to say buy an endo activator or buy an ultrasonic or buy an endovac or a son endo, unless you've got maybe $90,000 lying around. Use the tools that you have at your disposal. Moorer and Wesselink back in the early 80s talked about agitation of irrigant long before any of that stuff existed on the market. So again, you don't beat yourself up and say, wow, I wish I had an endo activator because it'd be great. There are very few studies that actually show the efficacy of a lot of these products, but there are systematic reviews that will tell you agitating the irrigant will help, okay? And of course, we often encounter problems too, and this again is feeds into our hysteria. So sometimes a patient will taste bleach. So relax, don't worry too much about that. What's actually happening here? What's actually happening is that there's a leak somewhere, either in your restoration or in your rubber dam. So to refer back to our restorability webinar, pre-treat the tooth. a 4-walled cavity, get a nicely adapted restoration so you don't have to worry about this stuff happening and stressing you out. If it happens, stay calm. Take the frame off the rubber dam, put some water into the patient's mouth, or let them have a rinse. It's okay when they have rubber dam on. We don't want to be too controlling and too absolute or rigid and say, oh, but you can't have a rinse because you've got rubber dam on. If they can have a rinse and they can swallow, let them have a rinse. More importantly, avoid it happening. Use some kind of rubber dam sealer. Now, I've talked about this before, and some of you will have heard this. You can use Orasil, which is very, very effective, or liquid dam, which is very effective. But Fixodent will do the same job for you. One of the difficulties with Fixodent is that it's hard to get it into a syringe to dispense it because you would need to put a disposable tip on it. And although the cost of the Fixodent is minuscule in comparison to the other two, the tips may kind of mount up in terms of cost. Now, I didn't come up with this on a kind of a crazy night thinking about endo. When I worked in practice in Australia, where they don't use instrument single visit, and they had this idea of using this, and it worked incredibly well. It did create a lot of kind of debris for the patient afterwards. So, you know, when you took the rubber dam off, it was kind of on the soft tissues, but it will brush off later. Orasil does the exact same thing. So there are little things that you can take away and potentially say, well, you know, maybe that will reduce cost, but it will adhere to the biological goals that I'm setting out to do. And then we look at hypochlorite accidents and you think, okay, I hope this doesn't happen to me. And you see all this crazy stuff that you find on the internet, but this is a patient after a hypo accident. Yeah, okay, 1 in a million. This can happen, but the key is 2 things. Number 1, you stay calm and you manage it according to the protocol. You explain to the patient, okay, I understand you're in a lot of pain. I'm going to manage this now. A little drop of our irrigant has gone out to the end of the root and it's creating pain. So the first thing you do, you leave your rubber dam on, you reassure your patient. Your nurse now, 4-handed, is getting your saline ready. You're not all flapping, running around in a circle, helping and trying to open packets. Your nurse is establishing the protocol. And we have a written protocol for this in the EDI, which we are in the process of rolling out across NHS Lothian, because I think this isn't reported well enough and we're not given enough guidance on it. And it's really scary when it happens. So your nurse is getting ready your saline, you then irrigate with your saline, you rinse out your canals. The next thing, the patient's in pain, administer some local anesthetic, explain to them that will resolve the pain, reassuring the whole time. And then you dry your canals, you get some calcium hydroxide in as best you can, you put a temporary restoration on top. You don't leave the tooth open. You don't. The evidence doesn't support that anymore, so that's not a good idea. But the next most critical part then is your follow-up. And I don't mean by follow-up that you say, here's antibiotics, here's steroids. Both of those are suggested, but not necessarily proven, and not necessary in every case, more importantly. But you say to your patient, this is what's going to happen. It's going to be sore. You need to take these painkillers. And we've got loads of advice. And one thing, as I said last week, we're going to become really good at managing emergencies and advising patients on the phone after this. Really, really good at it. So take that positive away and say, you're going to be able to deal with a patient 24 hours after this happens better than you ever have before. But that follow-up call and saying to the patient, how are you? How sore is it? Have you got any swelling? How does your face look? That's the important part. And if you worry about it at that point on day 2, you say, come back into me. Come back in at 5 o'clock, let me have a quick look. And it's about reassurance. It's about saying to them, okay, you've done the ice pack, you're on the ibuprofen, you don't have any signs of infection, there's no ulceration, we're not going to give you antibiotics, but I'm going to talk to you again in a couple of days' time. And 4 days after this happens, your inflammatory response, it's ramping down on the other side, and you're starting to get a patient who's improving. But don't let this freak you out and affect your confidence too much, because once we stay calm, we are fine. And the same thing applies with broken instruments. I don't want you to look at this. You look at this case, this was referred into me many years ago. This case, I think, is about 12 years old now. But the patient had a separated instrument. The patient was, and I'm sure you guys have been through this, and I've been through it loads of times myself, there's a blame element to it where the patient says, you've made a mistake. Yeah, it is a mistake, and own up to that mistake. It's not us going, oh no, it's a separated instrument because of nickel titanium and because of the cyclic fatigue. Don't confuse them. Just say to them, okay, a little piece of the instrument that I was working with has come away in the tooth. The key here is consent and communication. And both of those are the exact same thing. So when you consent a patient, you don't scare them and say, okay, I could break an instrument. You tell them how often it could happen. You tell them why their tooth might be a bit more relevant. So if it's got an acute curvature, think back to the assessment of curvature. Is it a really acute curvature? Is it an elderly patient? Do you have limited access? Did an instrument break in a patient's tooth before? All of that should affect your consent process, because you're saying to a patient, Does the fact that I could break an instrument really worry you? That's what you're establishing. You're not establishing, can you cover your behind in terms of when it happens? You're establishing what the patient feels about this in terms of consent. That's the key. Because a patient may say, and this has happened to me loads of times, I will do it and I'll say, okay, so it's in there and we're going to review. And they say, yeah, that's okay. I'm not worried about it. I don't know if I'd react like that myself, I have to say, but that's what lots of people are like. And that's what you want to establish, because if a patient is highly anxious about it and it happens, you need a plan. So your communication is key at that point, and your communication is key when it happens. So you say to them, okay, it's happened. I told you it could happen X% of the time. And it has happened. But what's important? When did it happen? So how much cleaning had you done? Don't say to the patient, oh, I'm sure it'll be fine. No, because it might not be fine. And don't say, oh, it'll fill the root canal. It'll seal it. Nothing seals the root canal. Don't say that to them, because when it fails, you're then backtracking immediately. You say to them, well, okay, the tooth didn't have a periapical radiolucency. So the evidence tells us, and this is happening in your mind, not your patient, but you say you don't have infection around that root. So we know from the papers that there's a limited impact of this on the chances of this treatment working. And then you finally say to them, but we're going to reassess you. We're going to make sure that you're comfortable. We're going to check in a few months to see what your tooth looks like on an x-ray. And then we're going to figure out whether we need to refer you or whether we need to have another go and decide what to do at that stage. So you've got to be aware not of metallurgy of instruments and why instruments break and what they look like under transmission electron microscopes when they do. You need to know how often it happens. And this is a nice study from Hal Duncan's group in Trinity in Dublin, where they look at the incidence of fracture being, take your maximums, okay? So 0.4 to 5%. So that's 1 in 20 cases. That seems high to me, but that's dependent on a multitude of factors. Work your own figures out. You'll be able to do that. And don't say, oh, it never happens to me. Last time it happened to me was like 2 years ago, and then it happens to you three weeks in a row. Stainless steel instruments, slightly higher incidence of fracture, but that's often because you're using them in the initial glide path stage. And more importantly for me, they're easier to remove anyway. So they're not as concerning. What else do you want to know or tell your patient? You want to know whether it's going to have an impact on outcome. Look at the success rates of these teeth with retained fractured instruments. Retained fractured instruments. 91.8% and 94.5%, and healing with a periapical radiolucency 87 against roughly 93. So look at that. You've still got really, really high success rates, and in the absence of a periapical radiolucency, this is going to have a limited effect on outcome. Really, really important. And equally, if you look at the last line, you will see that prognosis was an effect in the hands of endodontists. Now that's important, because if you refer a patient, you want to say to them, I'm going to get somebody to have a look at this, give a second opinion, and they may or may not be able to remove this instrument, or they may come up with a different strategy, because a lot of these instruments, particularly if they're round curvatures, although you will go to lectures where people will show you, look, I took this instrument out and this and this and this, some of them are very difficult to remove. But that doesn't necessarily mean, number one, that the patient needs any further treatment, or number two, that you can't treat the tooth surgically and remove the fragment. And then kind of in relation to the complications we look at, flare-up is probably much more common than fractured instruments. And this is slightly different. And the reason I've put this up is to get this into your mind, because often when a patient experiences a flare-up, you think to yourself, hang on, what's going on here? And anecdotally, these patients always come back and they will say, okay, it was fine for the first day. I had no pain. And that's an alarm bell straight away for me, because I'm thinking, hang on a sec, it should be sore. And then what happens is you've irritated the bacterial biofilm. It takes 24 hours for them to get really angry. And then suddenly you end up in a situation where, bang, there's your flare-up. Patient comes back, intense pain, swelling. You got to redress these teeth. And the reason I put this up is that we have to think about where we go after this lockdown and what we're going to do in terms of our management of our patients, because there's going to be an awful lot of emergency dentistry. And I don't mean emergency dentistry, oh, look, I have chipped restoration, or these are going to be true dental emergencies that have been essentially very, very difficult to deal with during this lockdown period. So for example, if incomplete instrumentation leads to flare-up, if a patient presents to you with an apical periodontitis, you don't want to do a tiny little bit of instrumentation and scratch the surface. Go through the scenarios. Irreversible pulpitis, the goal is to lift the roof off the pulp chamber and get some kind of dressing in. It's the pressure associated with the increased vascular flow that is mainly causing your symptoms here for the patient. So again, you take that message to your patient and you tell them what you're going to have to do. You explain to them that, yeah, anesthesia in situations like this could be difficult, but the reward, if I can lift the roof or even a partial roof off the pulp chamber, the reward in terms of reducing pressure is great. Okay, really, really great. You look at apical periodontitis. We know from the literature that if I do a little bit of instrumentation, we might cause a flare-up. So in a situation like this, you say to your patient, me opening the tooth up today and putting a size 10 file into the top 3 millimeters of each canal is likely to make it worse. You look at the situation, you say to the patient, you're in pain, I'll treat you with analgesics, and you know your analgesics, and you know from our first webinar, you know how they work, and you tell them why they're going to work. And if you need to supplement it with antibiotics, you pick the right one in the right dose for the right length of time, and you familiarize yourself with that. And don't forget that stuff, because as I said, one of the silver linings here is we're going to be really good at this going forward. For a flare-up, you identify what it is, you listen to the patient. You don't interrupt them after 12 seconds, like we looked at in that first webinar. You say, what is it? Listen to their description of symptoms. You diagnose it correctly, and then you go in, you re-instrument the tooth. But you don't create flare-ups and problems for yourself. Cracked teeth, biting on a hard bit of seed, it feels sore when I bite onto it, bit of cold sensitivity, you correctly identify it, and then you potentially put a stainless steel band on or maybe a GIC overlay, but you identify it and you tell your patient what's going on. And then we go back to our 3A's approach, which again, not harping on about it, but we can use that now, and we can use it, I think, more effectively than we have done before. And I think that is really, really important. Someone asked in terms of the dressing material that I would recommend, and this is important because is it leather mix or calcium hydroxide? And you know, the head of my program in the Eastman would kick me, I think, if he heard me saying that leather mix is useful, but it is useful on a practice level. And I know, again, if there was a nodding function on this Zoom webinar, I'm sure I'd be getting lots of nods, because it does work. Because although theoretically there's a risk of antibiotic resistance when you put in, it's got a steroid in there. It turns down the inflammatory system. Now, I'm talking about a tooth with an irreversible pulpitis. You can put your leather mix into your pulp chamber, not a tooth with a deep restoration. A tooth with a deep restoration, if you put leather mix on top, you'll ultimately end up with the tooth becoming necrotic. It will buy you time, no question, anecdotally and symptomatically, but it's not necessarily biologically going to do what you need to do. And another really good question, questions are good today actually, which is, do I discuss hypothyroid accident with the patient during the consent process? I don't routinely do it. I would discuss it with the patient if they specifically asked me or delved into the irrigant choice and delved into why I was using it, or if a patient turns out, and I don't say this in a negative way, if they're a red flag in terms of the consent process, asking lots of questions that maybe ordinarily patients wouldn't ask, and they have the right to do that, and I don't get defensive. I just may say to myself, hang on a second, maybe I need to talk to the irrigant, but routinely, no, I don't talk about hypo accidents. And of course, sometimes we don't need to use medicaments. And another take home for today is you don't routinely have to do multiple visit endo. I said earlier, vital teeth with irreversible pulpitis, and coming out of this lockdown, you won't have the time in your diaries to just be able to say, well, I'll just book in a whole session. You may find yourself doing multiple kind of single or first visits and emergency patients, but there is no difference between single or multiple visit treatment. There definitely isn't a difference between single and multiple visit in terms of outcome. But that said, we know that calcium hydroxide reduces bacterial load and it buys you a bit of time. And sometimes you can't get your apex locator to work. And sometimes you got a patient with a persistent bit of tissue that's giving them sensitivity. And sometimes you can't dry a canal. Situations like this, where you open a tooth up and you say, okay, I've taken out my root filling, and this palatal swelling, anytime you see a palatal swelling, it's an alarm bell. They're really hard to manage, very hard to dry up, and you can see the size of the defect surgically. And this, I have to say, I love putting this up because, as I said to you before, I don't want to put up all these cases where it's like, oh, look, this is amazing, and this is the case I did. The hemostasis here was a nightmare, and it's a disaster. You can see how much the patient is bleeding. He had been through so much with this tooth, and this was the hardest surgical procedure I think I've ever done. And it wasn't successful ultimately. So after a dismantling, a root canal retreatment, a surgical procedure, patient lost the tooth anyway. And so for me, looking at that, sometimes maybe those red flags, and it's interesting because people ask about consent all the time. Sometimes we fall into this idea that, okay, the next step is a surgical procedure, and the next step is this, and the next step is this, and we're guiding our patients through the consent process. Whereas realistically, looking at this now, it might have been worth removing the tooth from the outset and just enucleating out whatever this was, this little piece of tissue, because ultimately when the tooth was lost, it did resolve. So it's interesting. Don't make the consent too much of a kind of a this is what we're doing. Make it about you identifying where the patient's expectations and their concerns are. And then the final thing I want to say about instrumentation is sometimes we do it so quickly and we're ready to go, and then we're taking radiographs, and we take a radiograph and the cone looks short. And we look and we say, but why? Why is my cone short? And you look at it and you think, I've instrumented it and I've taken it out of the packet. Another take-home message for today: the cones are not matched to the instrument. The tolerance of the instrument is 2% and the cone is 5%. So you could have a 25 instrument and it's actually a 23, and you could have a 25 cone out of the box that's actually a 30. So that's why they sometimes don't match, okay? Sometimes they don't match because your prep's not right, but don't always assume it's your preparation. So if the cone doesn't fit, get a size matched to the size of your rotary. So if you use the next two, get a size 25, but a normal hand file, measure it to length, put it in the tooth and tap it gently with your finger. And theoretically, if you do that, the file should go right down to the depth to which you've prepared it, and that will tell you the prep is right, and then get a different cone. Don't automatically say, I'll put my finishing file back in again, because in a tooth like this, you'll start to transport the curvature, or you'll go through the apex, which has implications for your obturation, your irrigation. Think of the paper from Boutsiaka's. It's technical problems. If you blow the apex, you're more likely to put irrigant out there. It's a maxillary tooth. 85% of maxillary teeth suffer from the incidence of hypotoroid accident. It's 85% in the maxilla and 15% in the mandible. So don't automatically assume that what you have done is wrong. Equally, be harsh on yourself when you take radiographs. Sometimes we don't get the apex, and I do this too, and you think, that's okay, I have enough information from my grade 3 periapical radiograph. We don't. It's just that we don't want to say to the patient, I'm going to take a radiograph again, or the first one was so difficult to take that we don't do it, but you haven't got the information you set out to get. Do you need to do a retake? And how many do you take before you stop? Position the patient correctly. I take all my radiographs with the patient lying down. I take off the frame, and I always get the patient to turn to the side so that the beam is aimed directly in there, and it allows me to assess how parallel it is much better than when the patient is sitting up, particularly for endo. And as a take home, use a green rin holder and always ensure that it goes over the bow of the clamp. Put it in and flick it over. I might, hopefully when we go back, because this is one of the things that I thought is quite important, hopefully we will try and get some kind of hands-on component to this as well. Maybe we're even here at home, I will be able to show you how to kind of seat the x-ray holder, but I think that's really important. Take the time to position it correctly before you expose the patient. So the conclusions for today, okay? Establish a system for you. Keep it really simple. Minimal files, get your nurse to help you, and understand the importance of irrigation in the shaping procedure. Trust yourself, okay? Don't be extra tentative, and put the instrument in and allow yourself to feel what it's doing, but only in the context of knowing your system really well and describing it to your patient really well. And finally, accept and understand the problems that you face, okay? So we will face problems, and understand that it's about communicating it correctly to your patient and saying to them, this is a problem we encountered, this is what happened, this is how often it happens, and this is what it means for your tooth. And don't use general terms like, I'm sure it'll be fine, and we'll check it again. Be concise and definitive with them, and only tell them things that you know that are factually true. You'll look back and see some limited evidence from this webinar, and that will help you. Use that as a guide, for example, for talking to a patient about instrument fracture. Don't quote papers, just take the message out of it and deliver it in layman's terms. So thank you very much for joining today. We are going to be talking next week. We're going to be talking next week about obturation, and I suppose its role and how important it is. And I think in terms of obturation, what I want you to think about is, it is just a surrogate measure of what we do, okay? It is just a surrogate measure. So we look at it and we look at the white lines, but it's about what we do beforehand. But what is it that we do beforehand that can make the obturation a little bit easier and look a little bit better? So thank you very much. Take care, everyone, for the next week. Hopefully we will be getting closer to getting back to practice and getting back to things being opened up. I hope everybody is well, and see you all next week. Take care, guys. Bye-bye.